Recording in progress.
Hello, everyone. My name is Scott Nicholson with the Judy Nicholson Kidney Cancer Foundation. And today I'm very excited to have Dr. Ricardo Paz-Fumagalli from the Mayo Clinic of Florida here to speak with us on the treatment of small kidney cancers with freezing and heat. Welcome, Dr. Paz.
Thank you very much. Good afternoon to everybody. It's a pleasure to be here with you. It's always so important to be in communication with the community of family members, friends, individuals with health problems that might benefit from hearing some of the things that we can communicate. So I'd like to talk today about treatment of small kidney cancers and utilizing methods that induce or exploit the tissue killing capabilities of high temperature, that is heat, or freezing. And this is in general referred to as doing an ablation. So you'll hear that word as we go along. So the first thing that always comes up is, what is an interventional radiologist and why is this person even dealing with my kidney cancer problem when it really should be the cancer doctor or the urologist? Well, as it turns out, we have a very active role in treating these tumors. Interventional radiologists, we are physicians that have been trained for a good number of years in utilizing medical imaging for various purposes, and one of them is to guide procedures. So we do it with a minimally invasive attitude that usually requires just punctures. Rarely do we do incisions. And most instruments are either metallic needles or things that look like needles or plastic tubing called catheters. So by using this type of material and by going remotely through small holes and just navigating our way around the body, we can do quite an array of different things. One of them is to treat cancers. And within that universe, one of those types of cancers that we can deal with is small kidney cancers. And pertinent to today's presentation, the heat and freezing probes that we use for small kidney cancers are manufactured in the form of needles. So it's all in keeping with what we in the interventional radiology community do and what we use for our work. So the advantages, the reason why interventional radiology is actively involved in these things is because what we do has numerous advantages that include that it tends to be less expensive because we're not making incisions and we're not stressing the body as much. It is less risky. Typically, it is less painful. Most patients are dealt with as an outpatient. They don't even have to stay overnight. So it's an in and out sort of thing, as opposed to a surgery where we have to stay at the bare minimum one night, usually 2 or 3. If it's a minimally invasive surgery, it requires a bit of a hospital stay. It can be in certain circumstances more effective. And many procedures that we do are done without general anesthetic, although specifically for kidney cancers, almost always we do use general anesthesia. Now, the first thing is, okay, what does the actual kidney cancer look like? Now, that's pivotal for our work because we have to be able to see it to target it. We have to be able to see it to recognize where it is, what its extent, and to be able to discern it from surrounding kidney tissue that we want to preserve. Kidney cancers come in many types, numbers. They can be multiple. It can be one or multiple. They differ in their locations, and also they differ in the degree of aggressiveness. So they're not uniform, but generally speaking, the single most important element is size. Less than 4 centimeters is considered a small one. Larger than 4 centimeters is considered beyond small, so to speak. And this is an example of a patient who actually had the kidney taken out for a cancer. And here you can see that there's the tumor itself. This is the normal kidney. And here's where the urine collects. The urine produced by the kidney meat collects here and then goes down this tube all the way down to the bladder. So this is the cancer itself. Interestingly, you can see how it has breached the confines of the kidney capsule and starting to grow outside of the kidney. So this is something that we would consider a large tumor because it's about 5.5 or 6 centimeters in greatest dimension. So this would not be an appropriate one for us to treat, but it would be definitely typical appearing kidney cancer. Now, what does this look like to us, the radiologists? Well, this is a CT scan that happens to show 2 kidney cancers in the same individual at the same time. Here is a larger, very heterogeneous kidney cancer that comes into contact with some of the vital structures in the middle of the kidney that can be easily harmed. And here on the patient's right, that is our left, there's this little thing that sticks out, looks like a pimple, but that's actually a kidney cancer that is much smaller and much less angry looking than this one. So you probably guessed correctly in that this would be appropriate for us to work with in a minimally invasive fashion. And this one is probably going to require a surgery. So typically what we will do in circumstances like this is split the work with the urologist. They will do a partial nephrectomy or a complete nephrectomy if necessary. And then we will go ahead and do a percutaneous ablation of this one to preserve the better of the 2 kidneys. Now, before we can talk about what we do, it's very important to have a basic understanding of where surgeons are coming from, because everything that we do needs to make sense based on what the oncologists and surgical colleagues have figured out over the decades, because this is nothing new. It's been going on for decades. So radical nephrectomy is by far the most effective cancer treatment in concept, but it's never so simple. It is definitely the best option for large tumors, and some can only be treated with a complete removal of the kidney, that is a radical nephrectomy. Now, there is also an option for a partial nephrectomy, that is just carving out a piece of the kidney that contains the cancer and leaving the rest behind. That is really important because it conserves nephrons, and nephrons are the units of kidney function. So the more nephrons that we leave behind untouched and unharmed, the better the kidney function that the patient remains with will be. And this methodology of the partial nephrectomy is particularly attractive in tumors that are of the same size that we like to treat, the ones that are less than 4 centimeters in size. So how do we know that a partial nephrectomy is okay to do? Well, our colleagues up in Rochester in Minnesota from Mayo Clinic in Rochester conducted a very large study a good number of years ago. As you can see down there at the bottom, in the year 2000, this was published. It's over 20 years old, but it's very applicable to today. What they did is they took a bunch of patients who had kidney cancers, and about 1,500 of them had radical nephrectomy, that is the complete kidney taken out, and about 200 of them had a partial nephrectomy. But to make a sensible comparison, to make a fair comparison between the two, what they did is they matched up cancers that had similarities in their stage, the size, the patient's age, the patient's sex, the year of surgery, because of course, something was done in the 1960s may have different outcomes than something was done in the late 1990s. So they also pair them depending on the era of treatment. And once they did all that, they were able to select 2 groups that they could compare. And what they found was 2 very important things. One is that the limited surgery, that is the partial nephrectomy, was just as good for cancer control as a radical nephrectomy. By a tiny margin, the difference was better for the radical nephrectomy, but it was not statistically significant. And the other very important element is that when they looked at how people's kidney function fared, there was a huge difference in that the people who went on to have chronic kidney failure were twice as many in the radical nephrectomy group. So this proves that conserving nephrons is of benefit to the patient without any substantial lack of adequate cancer control. So knowing this as a backdrop, what is our role then? Well, percutaneous ablation does this. The whole point of it is to mimic a partial nephrectomy, but avoiding the need for a partial nephrectomy. So it's the same concept, just performed differently. How do we do it? It's very simple. We need a way to look inside of the body. That's where the CT scanner or ultrasound or other methodology that uses medical imaging comes into play. We look inside of the body, and then we use that to direct probes that are fat needles that we just poke through the skin and direct it towards where the tumor is. We create a zone that is meant to kill, and it is meant to be targeted with a treatment. And we can use either heat or freezing. As it turns out, freezing is very straightforward. There really aren't very many variations. It is what it is. Whereas with heat, we can do it using old electrocautery technology, which works quite well, or apply microwave to it. For various reasons, we primarily use microwave, but radiofrequency ablation, which is the electrocautery, works quite well, and they are interchangeable. Here, what you see is something that we were just playing around in our lab. This is a beef liver, and this is a radiofrequency ablation probe. And the probe has these tines, which are nothing but electrodes that will transmit electricity in the case of radiofrequency ablation. In the case of microwave, it's electromagnetic waves. There's no electricity. It's like radio. And then we insert it into the liver and activate it. Here, do you see these little bubbles that are streaming down? This is steam escaping out of the zone that's being treated because it gets so hot that it starts boiling the water in that zone that has been defined by the probe. And here on your right, you can see the effect that it had. This was cut with a knife right through the area that was treated, and you can see how this looks like cooked liver. That's what it is. It's cooked liver. All of this, the majority of its water was boiled off, and you're left with a zone of death from extreme temperature. Now, this is what it looks like in a real patient. This is the probe being inserted through the surface of the skin, goes deep into the body, and you can see the electrodes being driven into the little cancer that's pooching out of the kidney. And once you have defined the volume that you intend to treat, you apply the energy. It heats up or it freezes, depending which method you're using. You give it enough time to act, and that's it. You remove the probe and you're done. So it's conceptually, it's very straightforward, and most of the time it's not that difficult to do. There's always tricky situations, but that's not what's important. What's important is that it simplifies tremendously the treatment of these cancers while preserving kidney. This is an example of what a microwave ablation probe looks like. This is in fact an antenna. This part broadcasts just like a radio station. This broadcasts microwave, and it has a certain distance that it acts. And it acts by shaking water and shaking molecules that are charged magnetically very, very fast. And it's like rubbing your hands. It creates frictional heat so that the temperature of the zone that's being defined by the probe starts going up as a result of the tremendous shaking. Now, how fast is it? It's extremely fast. If you look here at the bottom, the microwave ablation probe runs at 900 megahertz. What does that mean? A wall electric outlet gives you alternating current at 60 hertz. Therefore, the microwave is 15 million times faster than the alternating electricity that comes out of a wall outlet. That creates such tremendous speed of motion that the friction at the molecular level raises the temperature, and that's how it cooks tissue dead. Here on your right is a artist's depiction of what the microwave ablation probe will be doing. It broadcasts the microwaves and it heats an ovoid-shaped kill zone. Now, let's look at an example in real life. This is a CT scan image showing a kidney that contains a cancer. It is about 2.8 centimeters in size, which means that it is of an adequate size for us to treat. 5 months after we did the treatment, in this case it was with radiofrequency ablation, you can notice major changes. To begin with, it is smaller in diameter. It has already reduced in size, and the X-ray dye that is given through the vein for the CT scan is captured by the normal kidney, and that's why it looks white. Whereas the tumor that's dead and the scar that surrounds it that's dead cannot capture that X-ray dye that was injected and therefore looks dark. This is a sign of lack of life. It's lifeless, and that's exactly what we want. 9 months later, you can see how it continues to shrink down, and eventually you're going to be left with a smaller round scar that will be there forever, and there will always be an indication that something happened, but it's just a scar. Now, freezing is a little bit different. What we have here is a little, it's a small needle, but it's blown up for us to be able to see how it's constructed. And basically, there is an inner little tube through which argon gas passes. As it exits into this chamber, it drops in temperature very deeply and creates such intense cold that things start freezing around it. And you can see here how it starts freezing around it until you get this pear-shaped ice ball that is defined by the dimensions of the probe. If we have a lesion that's a little bit bigger, we need to use more than one probe. So we can create an array, as you can see here, and as the freezing progresses, these ice balls get progressively larger, and they start coming together until you're left with one big ice ball that forms as a result of the effect of all being run at the same time. This is an actual picture of my hand with 3 probes next to each other after it had been submerged in water for, I don't know, not even a minute. So you can see how quickly the ice forms. And this at first looks like a corn dog, but if you give it more time, it's going to become much more rounded, kind of look like a pear. You can see how easily these ice balls can come together and like literally allow us to sculpt a volume that we want to treat in situations where perhaps the volume we want to treat is not spherical. Maybe it has some extensions that we want to include, so you can increase the number of probes so you sculpt the zone that you want to treat. This is an example as we are actually doing a procedure. You have the tumor, and then at first, the normal kidney and the tumor look very much alike. As the ice ball forms, it starts looking dark. You can see this ice ball growing as time progresses. After 10 minutes, is even larger than it was at 6 minutes. And once the probe is removed and the patient is given some more X-ray dye, you can see how the kidney has turned white as a result of the X-ray dye that was given. Yet the zone that was treated remains dark because you've destroyed its ability to suck in that X-ray dye. So this proves right there at the time of treatment that we have been able to achieve the objective of harming this tumor to the point where it cannot survive. Of course, patients want to know what they're going to experience. And they always ask you, so what is this going to feel like? And that's a universal question. What we tell them is very repetitive because the experience is shared quite similarly among all the different patients. And typically, during the ablation, you feel nothing because you're under a general anesthetic. So I tell them, don't worry about the treatment itself. You're going to be just fine. You won't remember a thing. So what happens once they wake up? Well, the first night is actually the worst, but not necessarily a bad one. Some people have it rougher than others, but generally speaking, it's not that bad. You will have some back pain. Most people describe it as if they got kicked in the back and they're like sore, like someone just gave them a blow. That's expected, that's considered normal. Nausea is quite common. Personally, I think that a lot of the nausea comes from the general anesthetic, but the fact that you have created a zone of death is very unnatural. We're not supposed to have anything dead inside of us. So the body will react to it. And one of the ways that the body reacts when we feel ill is with nausea, right? That's why when we aren't feeling well for whatever reason, we may have a little bit of nausea. The body doesn't like things that are wrong inside. And you may lose some appetite. You may not want to eat. Maybe just like, oh, I don't feel like eating tonight. Just let me sleep it over. So that's the first night. It's usually not bad, and it quickly gets better to the point where the next day, everybody has breakfast and it's fine. During the first week, the back pain gets better, usually the first day or two, but it can be a little bit more prolonged. The nausea typically goes away by the next day, so the breakfast is usually not a problem. The appetite may remain decreased, but it will come back, and we don't consider that a problem either. Something that some people find a little distressing, but that we don't really are not bothered by it, is a temperature elevation. Some patients don't feel so well. They'll take their temperature and see, oh my goodness, I have a temperature of 101 or 101.5 or maybe 100. Temperature elevation during the first week is very common. And it's, again, the body's response to what it perceives as an illness, an injury or an illness. Whenever we get ill, guess what? We get a little bit of fever. So that's the normal body reaction, and that will go away. A bit of Tylenol helps that, and people feel better. And after a while, they realize it's nothing to be worried about. Lastly, fatigue. Fatigue is the worst for some patients because it can last up to 6 weeks. It can be very prolonged. However, the majority of patients either don't develop fatigue or get rid of it in the first week or two. So it's generally not a big problem, but fatigue can last a while. So, Dr. Paz, when can I go back to my normal activities? The answer is, in most patients, virtually immediately. The majority of patients who have kidney cancers are past a certain age, usually 60s, 70s, 80s. Especially patients in the 70s and 80s, they're not going to be doing anything crazy. They're not going to be running marathons. They're not going to go play football. So I tell them, just as soon as you feel like it, just go back to your normal activities. I will not limit your activities as a result of what we did. Now, why is that? Because the body will warn you. If it doesn't feel good, just back off. It's fine if you don't feel like doing something, just take it easy. But if you feel like going to work, go to work. If you feel like doing chores, do chores. There is no official or mandatory change in your activity as long as you're feeling fine. Now, if we were to do this in a youngster who's going to do something crazy, get up on the roof and try to, replace shingles or something, we will tell them to please take it easy because we don't want to stir the pot. But the majority of patients, no activity restriction. Now, who do we offer this to? Because obviously not everybody qualifies. So how do we go about this? We already decided that size matters a lot. What we call a stage T1A, which is less than 4 centimeters, is usually what we target. Have we done things that exceed that size? The answer is yes. In a good number of instances. And the reality is that the treatment is not as good, but in patients who may not have another option, it can be very good. So we will not decline treatment on someone who has a tumor larger than 4 centimeters, but there's got to be powerful reasons not to perform a surgery. So aside from the size, who else would qualify for percutaneous ablation? Well, those who are suboptimal candidates for surgery. And I'm very clear here and saying that sometimes this is a tricky one. Why? Because what may be suboptimal for one judge may not be suboptimal for another person making judgment. And typically, this happens when you pit the physician group against the insurance company. Because we may say, you know what, this person has had previous surgeries, things may be a little stuck, or, he had some cardiac stents in the past, he's doing fine right now, but his heart isn't the best. Maybe we should try to avoid a surgery and let's just do a percutaneous ablation instead. the insurance company might say, wait a minute, we already paid for his heart to get fixed. Now that it's fixed, just go ahead and do the surgery, right? So there are situations that make perfect sense why there would be a disagreement among various people who might emit an opinion. But generally speaking, if someone is considered not a good candidate for surgery, they probably will be offered a percutaneous ablation if the tumor is the correct size. Another group that we will work on preferentially is people who have multiple tumors. And that makes sense. If you have multiple tumors, you can't remove all the kidney tissue. You'll put that person on dialysis. That makes no sense. So if you can avoid committing someone to dialysis, well, that's the moment to think seriously about finding nephron-sparing alternatives, of which percutaneous ablation is one of the most important ones. People who already show up with some degree of kidney failure, that is a common group of people. Just today, I did someone who had a creatinine of 1.6. Many of you will be familiar with what that means. And basically, this is a person who is doing just fine, is nowhere near needing dialysis, probably will never need it, but guess what? Has a cancer, we need to treat it, and he's going to lose some kidney function. We have to try to find a way to reduce the amount of kidney loss. And therefore, this would be a very appropriate candidate that nobody can argue with us that would benefit from a percutaneous ablation. Then there are individuals who are just afraid of surgery, or they just say, no, I don't want a surgery, and just refuse it. Usually what I tell patients in that conversation is that they have to be careful, because there could be a denial of insurance coverage, and the bill may end up being the patient's responsibility. That is an awful situation to find yourself in, and we typically would prefer if we can justify an alternative to the standard of care, which is surgery, because we don't want problems that have to do with financials. Patients getting a big bill is a very distasteful experience, and we just don't like that. So be careful when you flat out refuse surgery without a good reason. Finally, there are families that have kidney cancers running them, and they can be multiple. And under those circumstances, you know that in the future, as decades go by, there's a very high likelihood that at some point you may develop more than one cancer, and you start taking away function. At some point, you will be left without enough. So what can we expect from the treatment? So what are the results? Well, the first thing we need to do is understand how we're going to measure a result. It shouldn't be a personal opinion. It should be based on data. And how are we going to generate data for this? That's where the concept of outcome measures comes into play. Why? Because we have to have something that's measurable to be able to say to a patient confidently, yes, this is going to help you for this reason. Now, outcomes measures are very commonly used in the oncology and surgical world, and our world as well. In the case of kidney cancers, these are the most commonly used outcomes measures. And as you can see, it all talks about survival. That is a statistical concept where really what that means is what happens over time. And we think about it statistically as, okay, what is the durability of something? A life has a certain durability. We don't last forever. Therefore, there's a duration of life. And that durability is referred to as survival. Now, a person might be perfectly alive, yet not have survived without metastases, right? That would be someone who who perhaps reached 2 years or 5 years or 6 years metastases-free survival. So we will use these various measures to be able to say how well or how badly we do. And this is a chart that will give you an idea of what we're talking about. If we look at recurrence, metastases, and cancer-free survival and that sort of thing, you will notice that heat-based treatments and freezing have statistically identical numbers. The majority of series published are much closer to 100% than 87%. And they really are not distinguishable. Therefore, whether you use heat or you use freezing, the treatment, as long as it's done correctly, will work just as well. In properly chosen patients, and I emphasize here, in properly chosen patients, the tumor is not expected to come back, it is not expected to metastasize, and it is not expected to cause death. These are perfectly curable tumors. Very rarely do we have someone who had a percutaneous ablation whose tumor came back with any aggressiveness. The ones that we have seen come back is usually not at the site of ablation, but is someone who has a tendency to form new tumors that are independent from the one that was treated. So what do we do for follow-up? What can you expect after the treatment has been done? We look at three very important elements. The first one is kidney function. The day you show up for follow-up, you already come with blood work. And that blood work includes a creatinine. And that creatinine, we are always very curious to see what it looks like. Because we want to know if, as a result of our treatment, there is detectable loss of kidney function. The great majority of patients, the creatinine is identical to what it was before the procedure. But let's use today's patient as an example that I told you had a creatinine of 1.6. That patient might show up in his follow-up visit. During his follow-up visit, we look at the labs and the creatinine might be 1.8 or maybe 1.9. And then 3 months later, it might be back down to 1.8 or 1.7. We do stun the kidney with a treatment. And if it's already shaky, we can deteriorate function. If someone is close to dialysis, and we do a percutaneous ablation, they are already teetering. And it is possible that as a result of that, they might end up requiring dialysis. But in the great majority of patients, we're nowhere near that. I have seen, gosh, maybe 2, maybe 3 patients over the last 20 years that ended up degenerating into dialysis as a result of a percutaneous ablation. So it's not common at all. After looking at the kidney function, we look at the treated zone itself. Is the tumor dead? That's really our question. And the great majority of times, yeah, it looks dead, looks fine, no problem. Now, that is immediately. Then we have to follow over time because a tumor might be alive microscopic, but we cannot see it. So in the next year, 2, 3, 4, we might detect a regrowth of tumor where it was treated. That's what we call tumor recurrence locally. Now, there is also what we call a metachronous recurrence, which is not related to the ablation. That is related to the fact that the kidneys are fertile ground for formation of tumors. How do you know that? Because the patient already showed up with one tumor. It only follows that if they could form one tumor, they could form another. Some patients form multiple. The most I have treated in one patient was 8 cancers. That is quite unusual, but 2 or 3 cancers is not all that unusual. Why? Because 20% of patients who have a kidney cancer will develop another one following after 5, 10, 15, 20 years. So it is not uncommon for people to have more than one. And finally, we have to look for spread. Metastases are generally to lymph nodes, lung, bone, that sort of thing. We rarely see that after a kidney ablation. That would be very, very unusual because the great majority of the tumors that we are asked to treat are within the curable range. The follow-up is very simple. As I said, we check the blood, we do CT scans or MRI to look at the site, and then there is no consensus how often to meet. But I like to check at least once around 3 months and then yearly for 5 years. If after 5 years there's nothing, then we spread out to every 2 years. I personally believe that we should follow patients on an indefinite period every 2 years. Some people will say if after 5 years you're fine, I don't need to follow you anymore. That is acceptable, but I do not subscribe to that because I have seen enough patients who at the 8th year, 10th year, or 12th year develop another one that I don't want to lose track of them. So, but every 2 years is a very reasonable interval. So I'm going to stop here. I didn't want to get too much into some of the technicalities of it because sometimes it's really not that relevant. But if anybody has curiosity about some of the technicalities, I'll be glad to get into it. So I will then just stay quiet, and I look forward to your questions.
Thank you, Dr. Paz. We did have a few of them come in. That was really interesting. I didn't realize that this was even possible until you had brought it up. And one of the questions that had come in was, when do you decide it's best to use freezing techniques versus heating techniques, and why?
That is actually a very common question. And my response to patients typically is, I do not know yet. And what I tell them is that I do not know yet when I have them in front of me in clinic, because circumstances change once someone is under general anesthetic and on their stomach, because typically we go from the back. When you get a CT scan or an MRI, you're flipped onto your back, face up. When you get these procedures, we flip you onto your stomach with your back up. Now, gravity exerts a tremendous amount of influence inside of the body. So sometimes things shift. Now, why would organ shifting matter? Well, if I think that there's a delicate structure very close, and I want to keep a really close eye on it because I don't want to injure it. Let me give you an example: gallbladder or bowel, or maybe the ureter that carries the urine from the kidney down to the bladder might be very close, and I need to be absolutely sure that I don't injure it. I will prefer freezing. As you saw in the pictures that I showed, the ice ball is very easy to see. So we can keep track of things much easier with freezing. Now, one of the disadvantages of freezing is that it does not cauterize like heat does. So bleeding is statistically more likely with freezing than with heat. Another disadvantage of freezing, or if you want to put it this way, an advantage of heat, something that might want us to choose heat would be, let's say you have someone who has 3 spots. And knowing that microwave is extremely fast, we can treat all 3 much quicker than we could with freezing, because freezing usually takes, gosh, if one microwave treatment will take me, of the actual treatment itself, not all the stage production, but the actual treatment will take me, let's say 10 minutes. The freezing will take me 45. Now multiply that 45 by 3. Now multiply by that 10 by 3. So sometimes, in order to reduce the amount of anesthesia, to reduce the stress on the body from being in a position that's uncomfortable, a lot of elderly men don't like to be on their stomach. It's very stressful on their body. Sometimes time matters, and we will want to use something quick to get the patient in and out without too much stress. So they're not identical. There is some nuance to it, but I want you to understand something clearly, which is that it doesn't matter whether you use heat or freezing. If it's applied correctly, it's just as good. The nuance is what we decide the day of the procedure. That's why I don't promise patients what I'm going to use. That's why I'm telling, I will be choosing the day of the procedure once we're ready to go, because that's when I will know what I want to use.
Understood. You may have answered this one, actually. I believe you had said that there was a 1 in 5 chance that cancers would come back and when it was removed. So the question was, if the tumor is removed via freezing or heating, what is the likelihood that it'll come back? That's 1 in 5. Is there any difference between, like, whether or not it's freezing, heat, or surgery, or does that affect whether or not it comes back at all?
That question indicates to me that I did not speak clearly. And do you mind if I go back?
Sure.
I'm going to bring up this chart here. I hope that everybody can see it. The recurrence-free survival, the metastasis-free survival, and the cancer-specific survival after either radiofrequency ablation or cryoablation is nearly 100%. The site that you have treated almost is guaranteed to never come back. Okay, so the treatment site rarely, if ever, recurs. The recurrence has nothing to do with the treatment. The recurrence here that I say that happens in 20% of patients is the metachronous tumor. What that means is that the kidneys have a genetic or a mutation predisposition to form tumors. And 1 out of 5 patients will develop a new, separate, and unrelated cancer that has nothing to do with the treatment. So let's keep that clear. The treatment is extremely effective, and those cancers, by and large, don't come back. It's the patient's body that will want to form tumors. So that is the recurrence that we're talking about when we say that 20% of patients have a metachronous tumor. I don't know if it's clear now.
No, that makes
it's a very
complete
important
sense.
distinction.
Yep. That makes that. Thank you for clearing that up for us.
So the treatment is extremely effective. What's not effective is the body at fending off the formation of tumor.
I see. Now, these smaller tumors, do they when somebody has them, does the patient exhibit the same sort of symptoms that they would if there was a larger tumor? I guess the question is more curious about how are these found? Are they typically found alongside a scan of a larger one that's causing a problem?
This is a very good question because it allows me to bring up a little bit of a historical context. How do we know that many of these cancers are going to behave without much aggressiveness? Well, we know that because decades ago, the only way that we would know that someone had a kidney cancer was they had symptoms. Maybe they were peeing blood, or maybe they had pain. They were found at the time of an unrelated surgery just by serendipity, or they were found at autopsy. And this is the key. Many cancers decades back were unknown. The patient lived his or her life ignoring entirely that they were harboring a kidney cancer. They would die from an unrelated reason. Back in the day when autopsies were very common, because they're not common anymore, but back in the day when autopsies were very common, the pathologist would come across all these cancers and they would be reported. So how do we go from that era to where we find ourselves now, treating a bunch of small cancers that cause no symptoms, patient has no clue that it's there, they don't cause any harm at an early stage. If you catch them at an early stage, they're totally curable. How do we come across them? Well, because people get scans because their back hurts, or the appendicitis that they come in with gets them scanned, and a kidney cancer is found by just coincidence. Or someone has vascular disease, maybe an aneurysm in the aorta, and then they get a scan. So the vast majority of tumors that we treat were completely unsuspected, and they were found by pure coincidence while looking at other things.
Awesome. Thank you for that. So I guess that underscores the importance of your yearly checkup and getting your scans.
Well, there is no such thing as screening imaging for kidney cancer. It has not been shown to be cost effective and to make public health sense. So scanning someone just to see if we find something for kidney cancer is not something that has been found to be worthwhile. Why? Because in order for screening a population, you have to have something that is readily available, cheap, easy to interpret, that can be mass applied to an entire population. You can't go doing CT scans massively in an entire country of 380 million people. You bankrupt the country to find a few cancers that are not even going to cause harm anyway, because we catch them early, that they're not going to cause harm anyway. So the reality is that there is no justification for screening for kidney cancer in this manner. So we don't do that.
I understand. Well, I think that's it for our questions today. But I want to thank you again, Dr. Paz. This was a very interesting talk. And I noticed a couple of people logged in a little late. If you did miss any of this recording, then it will be on our website and our Vimeo channel tomorrow. So, we'll pump it out on social media as well. And we do have some upcoming talks that you may be interested in if you check them out on our website at, over here, jnfkidneycancer.org. Thank you, Dr. Paz.
You're very welcome.
This has been great. Have a good day, everyone.
It was great participating. Thank you.